Hi, everyone. Welcome back to another episode of Beyond the Script. Today, we have Dr. Justin Hall with us. He is an emergency medicine physician and chief of the Department of Emergency Medicine at Sunnybrook Health Sciences Centre and the medical director of Toronto's Virtual Emergency Department and affiliate scientist at Sunnybrook Research Institute. He's here with us today. Thank you so much for being here, Dr. Hall.
Thanks for having me today.
So the first thing I would love to know about emergency medicine is what's something that you think is completely misunderstood about the ER?
The first thing that comes to mind really is while we're always open, we're open 24/7, 365 days of the year. So we're a great access point. But I think sometimes people think that we can magically solve every single problem that they might have. And really, we're not actually best suited for that. We are a place that deals with high acuity issues. We're a place where certainly when someone cannot access a family doctor or potentially a specialist, that we will be there for them. But I think one of the challenges we often face are patients who have chronic issues. So things that have been on potentially that they've had for even years or many months at a time, where maybe they haven't found an answer through other ways, but we're not always the best people actually to solve that. Sometimes a specialist really is the best person or someone who knows the patient very well rather than me meeting you for the first time.
Wow, but some people still kind of think of the ER as a place to go for that.
I think so because we're always there, right? And
Sure.
I think for some patients I've learned over time that there's a lot of frustration at times with maybe not getting an answer through other ways or through other team members that they've seen. And so they come to the emergency department expecting an answer. Yeah. And I'm humble enough to share and to say that, you know, if many other specialists maybe haven't figured it out over a much longer period of time, I'm probably not going to have that aha moment just to be able to solve it immediately. Whereas when a patient comes and maybe they do have a chronic condition, but something has changed, it's become more severe, or now it's more debilitating to their daily life. If there is one of those changes, that's a great opportunity where I can probably help. I can probably narrow down what's happening and really get them on the right path. Yeah. But if something is very, I'll say static, or it hasn't really changed, but it's very bothersome for the person, it's often a very challenging experience because we want to be able to help and we want to find a solution for people, but it may not be possible in this environment.
But they kind of think of the ER as maybe they don't have an alternative doctor to see, so they go to the ER. Because from what I've heard is the ER is, like you said, it's always open and you'll take people in if they need the help. And so maybe that's why that's their solution, I guess, but it's not quite the right one always.
Yeah, I think you're right. And sometimes it's due to the lack of access of primary care. Yeah. We know that's a huge issue in the province right now. And working in the emergency department, that's something that I experience every day with patients. About 20% of our patients do not have a family physician who come into the emergency department. So I think you're right that there's often cases where people are coming in because they may not perceive another option. And sometimes I think, you know, we have conversations, we try and get to a point of mutual understanding that maybe I can't solve their problem today, but we certainly do our best always to try and get them on the right path. And it might be connecting them to a family physician if we can now. It might be connecting them to some sort of specialist. And while they might need to wait for that, that person may actually have much more expertise in the area of sort of concern or what that patient really needs. And sometimes that's a really hard message to deliver because we are there and we do want to help. It's not always satisfying not to be able to give someone an answer.
Oh, absolutely. And like you said sometimes that can create a lot of frustration. Is the ER always a chaotic place? Is it pretty much that's just how it is, or is there some moments where it's maybe less?
Yeah, you know, it's an interesting question and one that I've been asked before. So I think as someone who works in the environment regularly, I would say I don't find it particularly chaotic. I think it's maybe more organized chaos, or it's more structured than the average person might think. We get very used to dealing with urgent situations. We get very used to dealing with kind of being pulled in different directions at the same time, and how you prioritize and reprioritize as a shift goes on, for example. But I think if you're someone who has generally been healthy and you're coming to an emergency department for the first time, I think it's completely chaotic. It's a loud environment. It's bright at all times of the day. It's usually very busy. There can be long wait times. You see people from all walks of life, and I think for those situations, I can totally appreciate why someone would think this is a very chaotic place to work in, and how could you work in this type of environment?
Yeah, that's a really good point that you said about for the average person, it would be a very chaotic place, but for you and your colleagues, this is your everyday. Like, you get quite used to it. And honestly, that's good, and I think that's maybe comforting for the public to hear of. It's overwhelming for us if we're there, but know that the physicians who are there, this is their everyday. It's not, we might panic about seeing something terrifying happening in the hallway of an ER, but for you guys, that's a pretty normal Tuesday. So
it is. I think one of the things we learn as part of our training, whether you're a doctor, a nurse, an allied health member working on our team, we are trained to recognize when things are maybe a little more chaotic, or to expect the unexpected. Right. We deal with uncertainty all the time. And so I think because that's our baseline or our default, it makes things a whole lot easier for us to kind of go with the flow. Yeah. But it's also very overwhelming for the average person who does come in. Even if you're sort of experienced in the healthcare sector, I think it still can be quite an experience depending on what is going on at the time when you arrive specifically, because that may look very different even a couple hours later.
Yeah, absolutely. Do you feel like you said your baseline is kind of expect the unexpected? Is that something that you have been trained to eventually get used to expecting the unexpected, or do you think there's some sort of innate quality that a person has to have in order to be an ER physician?
I think it's probably a little bit of both. I think one of the things that I rely on is many years of training. And what I say that is, sure, there's always textbook learning that you can acquire, you can learn from all of your colleagues. But being able to experience on the front line what happens when those sick patients come in and when there's constant interruptions, that's when I think you know if this is going to be a good fit or not. Yeah. And that then goes to sort of your personality or kind of who you are. And that's either going to be very stressful, and that might seem very chaotic, or that's going to seem, okay, I can manage this, and this is kind of exciting at times. So I think it's about trying to find that right balance, and I think some people are better suited to different specialties, different environments than others. Not to say that you can't kind of train and prepare for that, and I think that's what our training helps us do, is those two things coming together, and you realize that, I really love working in this environment, and even though there are challenges every day, it's something that I enjoy, and I keep coming back.
Yeah. Oh, it's great to hear that you enjoy it, and that would be a lot of other people's nightmare, but that's the type of person we would want, honestly, running the ER. So what would you say is like a normal shift in the ER, if there is any normal part of it?
I think a normal shift I would define as a lot of variety. And I guess what I mean by that is we often start our shifts with more serious or more acute patients. So those people who need kind of attention right away. This might be someone who is short of breath. Perhaps they have pneumonia that we've diagnosed and they need some oxygen to help them. It might be a person having a heart attack, for example. As we go on our shift, then we typically have those patients who are maybe sort of the walking well, a little bit more healthy, maybe a little bit younger demographic, maybe not as many medical conditions. Maybe they've sprained their ankle, for example, or maybe they have a skin rash that we're trying to help with. And then we end our shifts typically with what I'll say is more minor procedures or sort of quicker things for us. Still may be very serious for the patient, maybe a cut that needs stitches or a broken arm, and we need to put it back into position for the patient. So I would say a normal day for me really is a wide range of different things, everything from chest pain to abdomen pain to cuts and broken bones to skin conditions. And it's about putting all of that together, and that would be a pretty typical day for me.
Wow. How long are your shifts usually?
So our shifts are typically about 8 hours. We do have some that are a little bit shorter, typically at night, recognizing that it's a little bit harder for most people to be working overnight. And some are a little bit longer. And I think we work in a profession that also has a lot of flexibility, that if things are really busy or there's a lot of serious and very sick patients, we will do our best sometimes to even stay late or to try to do as much as we can to help our colleagues as well and to help the system.
Yeah. And that's 8 hours of like on your feet moving around, going from one person to another, and making very quick decisions. That's an exhausting 8 hours as well.
It is. It's usually, much of the time is spent on my feet, and some of that time certainly is spent charting. There's certainly time behind a computer, I'll say, reviewing results and preparing documentation as well. But I would say overall, a lot of it is on the go. It's constant thinking. It's moving from place to place and patient to patient. There's not a lot of downtime on my typical day. It's not uncommon that myself or our colleagues at the end of the day kind of think about it and said, oh, I haven't even gone to the washroom today. I should go do that.
Yeah. I was going to ask, does the day go by quickly then in that case?
I would say it does.
Yeah,
I
bet.
would say most days do go by very quickly, and I think for me, that's why it's quite enjoyable, is it doesn't always seem like work. There's always those days that are more challenging where just things aren't going the way that you would hope they are going, or there's system barriers, or all the tests are taking longer than you'd want. But most days are pretty good, and I think being busy does lead to a better experience, and you feel good at the end of the day. You feel maybe a bit tired, but you also feel satisfied that you've probably made a big impact too.
Yeah, absolutely. Because like you said, this is your everyday, but for the people in there, that's emergency room is probably the last place they want to be. And if you can do something to make them feel more comfortable or help them or make that experience a little less scary or traumatic, then I'm sure that feels really satisfying.
It does. I think for most patients that we see, this is probably one of their worst days when we see them. Yeah. It's a place they don't really want to be, but they feel that they have to be there. And in many cases, they do need to be there. And I think because of that, a success for me typically is, even if I haven't got the exact answer of what's going on with every single patient that I see, it's about eliminating those life-threatening diagnoses. It's about making sure I've tried to move this patient on the right path to make them more comfortable or to improve their wellness or give them reassurance in many times. So I think it's a humbling place to work in. It's also extremely rewarding, where I know that if I've just moved their care forward and I've really listened to them, I've probably made their day a little bit better, knowing that this was probably one of their worst days that they were having.
Yeah, absolutely. That's very meaningful. Is there something that patients do that makes your job harder or easier?
Yeah, I think one of the things that I think patients do that makes it easier would be when someone comes in, I'm going to say well prepared for their visit. And I guess what I mean by that is, a patient who does have some significant past medical history or surgical history, when they know what conditions they have, what medications they're taking, if there are any new changes, for example, any allergies that they have. Often we're seeing patients now come in, and sometimes family members will bring a list and they will have all this information for you. It just helps so much to make sure that even previous documentation is correct. And if there is a discrepancy, it gives you an opportunity to make sure with the person that you really do have all the information to help move their course along. I think sometimes things that can be challenging is we know that one of the things that can be frustrating for patients is not everyone waits the same amount of time in an emergency department. Right? Some people are seen within seconds to minutes, and there's some people who will wait hours no matter where you go for care. And I think that can be a frustrating thing, where one of the most common things that we're often asked is, how long will it be? When am I going to be seen? How many people are in front of me? And I think we always want to be able to give a truthful answer to people. And I can totally appreciate from the other side why that's an important question to be able to answer. And we try and predict this, and we have algorithms that do predict this and say how many patients are waiting. But the challenge is we don't know who's coming next. And when that next person comes who is critically ill, that now bumps that person yet again. And that can be super frustrating for patients. And I think it's challenging as a provider to constantly hear, why am I waiting so long? What is kind of happening here? And it's not that people are being skipped or otherwise, because it's not based on just time. It's based on the criticalness or the acuity of their presentation, and that changes constantly based on who comes in our front door. It's not predictable the same way that an office setting might be, for example.
That's a very good point. Like, this person's been waiting for 5 hours, and maybe they're about to, and then someone comes in, and of course, like, the person who's maybe very close to dying, of course, is going to take priority. And in a way, could be looked at as a good thing that you're not sick enough, but also I totally understand being frustrated with sitting in a waiting room for hours. That's
completely agree.
Yeah.
I've seen this on both sides of it.
Yeah.
Having friends and family who have needed care, and also then as a provider, you never want people to wait. It's not an enjoyable experience.
Yeah.
I know that very well firsthand, but also from all the feedback we get from patients. But having a little bit of patience and understanding to recognize, as you said, sometimes there's someone who is more sick and needs our care more urgently.
Yeah.
And in some ways, that's a good thing that maybe someone doesn't need to be assisted quite at the same time. But the other thing I share is everyone can be rest assured that we will get to people and we will see everyone. It's just a matter of how quickly we can do that based on who else comes in.
Right. You mentioned when maybe a critical patient comes in and that kind of then takes priority. What goes through your mind when multiple critical patients come in at once? How do you deal with that?
Yeah, and surprisingly, it's not uncommon.
I was going to ask also, how common is that?
It's one of those situations where, you think there's some predictability, but and sometimes we do have a heads up. For example, a patient who's having a heart attack that's identified by paramedics in the field, we will usually get maybe 5 or 10 minute advance warning.
Okay.
Same thing with a major trauma patient, for example, or a stroke who's been identified somewhere in the community. In those cases, we can prepare a little bit, right?
Yeah.
We can understand our resources. We can try to finish some things potentially quite quickly with who we're already working with, and then take a couple minutes to plan with the team who's going to be doing what roles and everything. I think where it becomes more challenging is you might know some of that, but then the person who just comes in the front door who's very sick and who needs to be seen right away, maybe they've got a really high heart rate or a very low blood pressure, or maybe their oxygen levels are very low. And in those cases, when multiple people arrive very close, either at the same time or back to back, it does become challenging. We call this crisis resource management. So in those times, very quickly, we are trying to think about, where do I need to be? What can I delegate to someone else potentially? Or what can I start for someone right away, maybe to stabilize them, and then go to the other person quickly to do something and then come back?
Yeah.
It's a different experience when I have worked in some rural environments where maybe you're the only physician on.
Oh, my
that
goodness.
makes it that much harder.
Wow.
Where you are still making those same important, timely decisions, but there may not be as many people to delegate to. So I've there are different challenges in both of these environments.
Yeah. Have you learned how to deal with those, or is that still something that you'll probably just always have to learn and get better at?
I think it's something certainly I've learned to be better at now than when I first started.
Yeah.
But I don't know if we ever kind of achieve perfection on that. I think it's one of those things where it really depends on exactly who's coming in. So we do have triage scores that our nurses certainly help with and can identify who's probably more sick than someone else. But there's a lot of time where we can't kind of get there necessarily immediately. And so we really do have to, sometimes I will go by multiple rooms and eyeball people and say, okay, all these people are sick, but I'm going to now go in this order. And I will verbalize that to our team and say, if something happens with this person or otherwise, let me know, but I'm going to be in this room. I will be coming to you next. And so we do constantly triage, but reprioritize depending on how someone might get a little bit better or might get a little bit worse.
And you can't predict that. Sometimes someone might be, maybe medically you can't even explain why all of a sudden this person is going in a worse direction than they were, even if they were doing well. And then that just changes everything, changes the schedule and 100%. The routine. Yeah.
Yeah, it really does keep you on your toes, and it really does mean you have to make those quick decisions, but you have to be flexible enough and comfortable with uncertainty. We're never dealing with perfect information about every patient. Maybe some patients you've already got their blood work back. Maybe another patient you're waiting for that blood work. Maybe someone else you're hoping that a little bit of early treatment's going to turn the corner for them, but maybe it doesn't. And so you're constantly reevaluating those things as well. Wow,
that sounds, there are lots of jobs that deal with uncertainty as the norm, but not all of them are their life or death situation. So that really takes a certain kind of person to be able to do that. That's amazing. You mentioned when you might get like a 5 or 10 minutes heads up of we have a trauma coming in. And you mentioned a little bit about how you prepare. Can you tell me a little bit more about how, is it you delegating people? Is it you hearing about, okay, this is the patient history, this is the information. How do you really prepare for that?
Yeah, and I will say it partially depends on exactly where we are and what else is happening in the department. So maybe I'll give it a tangible example. So
Please, yes.
If we have someone who, for example, might already be in our trauma bay, maybe we have a person who's designated as the trauma team leader. So they're sort of the first in command or in charge for a trauma patient when they come in. And when we do have that notice, that 5 minutes, 10 minutes, sometimes it's really helpful to be able to get a little bit of demographic information. So what's the sort of age range of the patient we're seeing? Is it a male or female who's potentially coming in? Because that might change the types of things that we get ready. And the mechanism of injury is really important. So is this a fall from a ladder? Is this a motor vehicle crash on the 401? What is it that's actually happening? This allows us then, we give an advance warning to our trauma team. So that involves some other specialists, like the general surgeons, for example, an anesthetist or an airway specialist as well, and also some nurses who will come to bedside.
Wow.
This allows us then to start planning what do we need, or what, based on this mechanism and these demographics, here's what we think will be our early priorities. We always check airway, breathing, circulation, but there's some nuances in terms of maybe procedures that we might have to do, like placing a breathing tube or potentially checking if there's blood in an abdomen. And that would change then what interventions we need to do. So we try to get the equipment ready. We try to all have a shared vision of what we're anticipating. And we also have to be flexible enough to know that when that person arrives, it might be a very different patient in front of us than what we think was coming in too.
Oh, I didn't even think about that. It might just, oh my goodness, that's a whole other thing.
Yeah, and sometimes that patient is arriving, but then you've, in the meantime, in those 5 minutes, you've received another call that another patient is coming.
Oh my gosh.
And so we do have capacity to work with or support multiple trauma patients at the same time. But sometimes then one person may not be able to take multiple patients because they may have a higher level intensity where that trauma team leader is now occupied with 1 or 2 patients, in which case we have always a backup plan where another one of the emergency physicians is now going to take that second or that third trauma, or we have to really be careful with our resources, and that's constantly in flux.
That's amazing. That's so interesting.
Yeah, as you said, medicine always changes, but I think in addition to that, there's some things that are common. They do become very routine in what we do. But there's always certain cases that are a little bit more challenging, or certain procedures that are actually very rare. Yeah. And I think we really try to enhance our skills of those types of scenarios as well, because we want to be prepared when that one case or that case of a lifetime comes in where you're like, okay, this has eased my nerves or my anxiety a little bit because we've at least practiced this.
Right. And if it's a really rare one, then you're out of practice. If it's not something you see normally, then you're not practicing what you need to for it.
Exactly.
Can you give me an example of something that would be a really rare one that's not as common?
Yeah. So, for example, a patient who comes in, let's say it's a pregnant woman, maybe 24 weeks pregnant, and maybe she's lost her pulse, so she's in cardiac arrest. The question now becomes, well, how do we intervene? And there's a procedure called a resuscitative hysterotomy. And in that case, this is an emergent procedure that has to be done where you actually remove the fetus or remove the baby to decrease the pressure on mom's aorta. The aorta is the biggest vessels serving blood to the body. And so what that does often is it can save sometimes that fetus or that newborn, but also save mom. And so that's a very rare procedure. It's something certainly that I had great training from other colleagues of mine, but it's not something that happens very often. So if you've not thought about it or don't kind of think about how to do that, time is really of the essence. This is something where you want to have started this procedure within a few minutes of seeing this patient. It's a quick decision, but if you're not kind of thinking or know about that, it can be a really daunting decision to make that incision in something where you're just not sure what to do. Yeah.
And 24 weeks, that's really early to have a baby.
It is very early. And so in that sort of scenario as well, we practice so that there have to be other teams that are often involved. So this might involve our obstetrics colleagues, for example, or our neonatal colleagues, because there is going to be a newborn there that we're hoping is going to have the best chance at life as well.
Have there ever been moments where a trauma patient has come in and you've questioned if you can handle it?
I would say yes. I'm very fortunate to work in a setting where we are very well resourced. So we have lots of people who can help. I always have at least another emergency physician that I can get to. And I would say I'm very fortunate that I work in an environment where we have access to specialists all the time. And I think knowing that I have a solid team, not just in the emergency department, but a solid team beyond that in the hospital who's always at the ready and willing to help, that kind of comforts me in those moments of I've never seen this before, this is new, or this is just a lot that we're dealing with right now for this patient.
It's comforting to know you don't have to necessarily do it alone. You have people you can turn to who know maybe more about a certain specialty.
Exactly. And I think being able to recognize when something is overwhelming or is new to you or is just too much, maybe because you have so many patients on the go, recognizing that and being able to take the steps to ask someone else to help and being comfortable enough to do that or explain the situation, I think that's really important.
Absolutely. Are there moments where you have to go from kind of a life or death situation and then walk into another room and talk about mundane, or not mundane, but just say like, oh, you have a sprained ankle or something?
So this happens, again, not infrequently, where you have a patient who's critically ill, and maybe you have an end-of-life discussion or a goals of care discussion either with that patient or their family who might be with them. And in some cases, maybe that person does pass away under your care while you're there. You've done everything possible to support them, or the wishes of that patient are to pass. It's really hard to go from that because it's emotionally draining at times. Even if you're doing the thing that patient and their family wanted and they've expressed that, it's still hard to see, hard to experience. And I think in this specialty, you have to be able to sometimes just take a quick breath, potentially to reflect, take a moment, but then also to be able to compartmentalize and move on quite quickly to that next person who might be very serious, or as you said, could be something very minor, but still giving them the time that they deserve for their issue and their concern, and not having sort of that emotionally charged or draining experience impact them. So we really have to kind of refocus quickly. And that kind of goes back to one of the things you mentioned earlier, that we're often on our feet and we're often very busy moving from one type of presentation to another. And I think sometimes it just you kind of have to put things aside temporarily to be able to do that, so that you show up fully for that next patient.
Yeah, and you just have to learn to do that, I guess. Are there things that you do to help yourself mentally after a shift that was maybe particularly emotionally heavy?
Yeah, so I think this looks a little different for everyone.
Sure.
And so for me, I'm someone who I can usually recognize when I need a minute or some fresh air, for example. So whether it's sometimes after that really challenging case or potentially at the end of a shift, sometimes all I need is actually to take a couple minutes and go breathe a few deep breaths in a quiet place or outside sometimes even. When I'm done a shift, and usually after that, one of the things that I usually do is I like some type of activity. And so I usually either run or sometimes bike to and from work. And what that often does for me is it gives me a bit of time to decompress. So I sometimes will reflect and I'll think about those patients that I saw. I'll think about those challenging cases and what maybe provoked emotion in me. And I think being able to do that is quite healthy, but it also allows me to kind of recenter or rebalance as I might be going home to family or friends or another event that I have to go to. And so sometimes just having time both to myself is really important, and doing some type of activity that's very different is helpful.
Do you find yourself ever, is it normal or is it more rare that you find yourself thinking about cases once you're like home and like making dinner or getting ready for bed do those things still linger in your head sometimes?
Sometimes, yeah. I think I'm pretty good about being able to sort of separate, I'll say, the clinical work from other elements of my life. But there's always those cases sometimes that make you think for one reason or another. Sometimes it's a case that went really well, where, someone's acknowledged, wow, that was a really good pickup. That's a rare situation or a rare diagnosis. You picked it up. This person's now going to do much better than if there was a delay in getting that. Yeah. Sometimes you think about those, and those are positive moments to be able to kind of reflect on and remember that, this is very satisfying and rewarding and you've helped someone. And there can also be those situations where maybe things didn't go quite as well as you would have liked. And in those situations too, I think those moments do come up. You're making dinner and all of a sudden I'm thinking, oh, I should have done this, or why didn't I think about that at the time? And I think we all have those types of moments when I talk to my colleagues. I think it's how you process that so that it doesn't become all-consuming to everything else that you're doing. So sometimes I do have to kind of take a step back. I need to think about that, maybe address it, maybe talk to someone, and then I can kind of move on to everything else that you want to do in your life as well. But I've had both of those experiences. Sometimes they're sort of constructive opportunities or something where, for whatever reason, it just kind of pops in your head, and it may not be always clear why that moment has come up, but it's sometimes a really helpful learning moment. And sometimes it's a more of a rewarding moment of something that I'm very happy about, and it kind of it makes it all worthwhile.
Yeah, I like that you said the positive moments too come into your head, because I feel like people think about, I feel like the public might think about ER physicians and how things weigh on them kind of negatively, of, oh, this was a really, really traumatic case today and I still am having a hard time getting over it. But I like that you said that you also think about the positive moments of, wow, we literally saved a life today, or someone caught this diagnosis early on, and that will give this person a few more years of life, or whatever it is. I like that you said that there's also the positive things to think about.
Yeah, I think both are important things, and we often do remember the things that don't go quite as well or wasn't the outcome we wanted, kind of more than the 20 patients we saw where they all had good outcomes, they all had the things that we wanted, we helped them. So I think keeping that in perspective helps with longevity too, and your overall wellness and everything.
Without sharing identifying details, of course, is there a case that comes to mind that's like kind of maybe the weirdest thing that's happened in the ER, most unbelievable thing that's happened in the ER? I'd love to hear some of those if you have any. Yeah,
it's funny. There's so many probably different cases that I could bring up. One that comes to mind is someone I saw a few years ago who, this was a person who I think was working on a stepladder, quite tall up, and they fell backwards. And when they fell backwards, there was a low sort of metal fence. And unfortunately, they kind of, their back went into the fence, and you can imagine almost like an arrowhead of metal that went right into their back.
No.
So I'm envisioning, because I wasn't at the scene, but based on what our paramedics and our team told us, and the fire department who was there with them, is this person almost looked like a scarecrow, you can imagine. Like they're kind of pinned onto a metal fence.
Wow.
And so, the natural instinct might be, okay, we'll pull the person off the fence.
Yeah.
But based on this going into someone's back, for example, this could have been very close to their spine. This might be through their lungs or their heart even. You don't kind of know.
Yeah.
Now, the interesting thing of this patient was this is someone who was still talking and breathing comfortably at the time.
Okay.
So the question was, do you try and remove or do you do something else? And often in this case, and as they did here, the fire department actually cut through the fence and brought in the patient with a portion of the metal fence sticking out of their back.
Oh my gosh.
There's a variety of reasons why this is memorable. Just
what
in
a thing
itself.
To see wives you just see enter the room.
And so this person comes in who just looks quite well, surprisingly. They're
Wow.
talking to you, they're conscious, they're aware, they're alert, they know what's happened.
Okay.
But they've got a metal bar sticking out of their back.
Was it like through their...
So it wasn't through and through, meaning not through their back and through their front, but it was into their back, stuck in them.
Oh, gosh. Okay, yeah.
And so our question is, what structures has this potentially damaged, and is this even, it could be through, for example, an artery, but if you take it out, the person may start to bleed out.
Right.
And so you kind of keep part of this in there. But the challenge also, and the unusual part of this is, when you see this person, normally we lie people on their back. We do an assessment of their airway, their breathing, how their, their pulse and their circulation. But we can't put the person on their back because they have something stuck there.
Yes.
And so we actually had to kind of put this person on their side to be able to examine them appropriately, to get some x-rays to see kind of where we thought. And it's a challenging thing, but eventually this person went to the operating room to have this removed in a safer environment. And they did quite well, almost miraculously. They didn't have long-term nerve damage. They didn't have major injuries to their lung or to their heart or other internal organs. So it's kind of an interesting one for me because you never know. I almost assume when I hear that type of call, we answer what are called paramedic patch calls. So where a paramedic is in the field with a patient and they call into us, sometimes asking for advice on what to do. And I had a vision in my mind of what this looks like, and certainly the paramedics described this very well to us. But it kind of makes you wonder, like, how does this person seemingly look so well despite this?
Yes,
so they're very memorable cases there because it's so it's really a rare phenomenon or a rare case where someone did so much better than I would have anticipated based on what was described to me.
Wow, thank you for sharing that. That's a really interesting case. I was going to ask you, like, has there been something that has happened where medically should not have, like, a patient has survived something and medically they shouldn't? It sounds like maybe that was something. You said there was no nerve damage or anything.
Yeah, I mean, that's one. I can think of maybe another case that one of my colleagues actually had a couple years ago, and I remember they came to me also asking for help. It was a middle-aged gentleman who had fallen through ice in the winter and sort of got submerged for a little while and then lost his pulse. So he was in cardiac arrest, and he was being brought in to us. And we had
was he underwater, you mean? Or
so he kind of went through the ice, and my understanding was he kind of got trapped on the ice, so he couldn't get back out immediately. This was a witnessed event by, I think, a family or a friend. And so they called for help right away, and they were able to kind of bring the patient out or retrieve the patient. But at that point, the patient didn't have a pulse. And what's kind of interesting in this case is because the person had been submerged in winter, they were quite cold, so they were hypothermic. And there's always this decision point as to kind of what happened first. Did they have some type of like heart attack or an event, and then they kind of got stuck in the snow or went under ice, or was it just a simple fall or something, and then they had the heart attack or lost their pulse? Why that kind of matters, or maybe it matters less, but what you do with that is, this patient was still brought to us because they were so cold that we needed to rewarm them first. So you can be cold and dead, but we all will always kind of say that someone needs to be warm and dead first before you actually say that they're truly dead. And so you try and rewarm the person with fluids and different strategies, warming the temperature of the room, for example. And sometimes you need to have tubes placed in you to be able to increase the temperature of your internal cavities. But once you get to a certain level, it becomes such that sometimes people do regain their pulse. And then their body can function again normally. And that happened to be the case here. I remember when this person came in, and it's one of those things where you think, like, this person has died. They're not breathing. They don't have a pulse right now. But once you got them warmed back to a closer to normal temperature, they actually survived and did quite well.
Oh my goodness, that sounds terrifying, first of all. Like, oh my gosh, but those are the kinds of things that you guys see. That's, wow.
They are, and they're the things you kind of remember, and where you say, you hope you never have to see this, but I also hope that I'm comfortable enough and prepared for it when it does happen.
Right. Yeah, and you want to be, so it's not something you necessarily want to think about or practice often, but you want to for the time that it does happen. It's worth it for the maybe one or two times.
Exactly.
I have a couple more questions. this might be an annoying question because you're an ER physician, but I'm wondering if you've watched any of the Pitt.
So I have.
Okay. I'd love to know your thoughts on it.
Yeah, so it's funny, and I've been asked this question by a few people, both who work as colleagues of mine directly, and then other people who maybe work in other areas of medicine or not in medicine.
Okay.
So I have been watching it. I find it quite interesting.
Yeah.
I will say I think they've done a really good job of the storyline in the sense of how accurate some of the devices are, how accurate some of the protocols are that they talk about. It's actually quite realistic. Now, it is still dramatic, and I would say the caveat to all of that is so many things happen in a 1 hour time period on this show or in the course of a day or a shift as you go through the episodes, that's probably quite unrealistic generally. But the individual cases that are seen here, or the people who are waiting for hours in the waiting room, or when a code orange happens where several patients descend on the emergency department at the same time and resources need to be reallocated, or they had a code gray very recently where IT infrastructure goes down and they couldn't use their computer systems.
Yeah.
This is very real. We've experienced that before, all of these situations. So I think I enjoy it because I can see a lot of similarities to the type of work I do. And I think for someone maybe who doesn't work in my environment, or when I talk to my family about things, it gives a different lens or a visual to sometimes the things I try to describe. Yes, animated at a higher level, but I do think quite well done in terms of the overall storyline.
Wow, that's really cool. Like, it's maybe not all these crazy cases happening within 1 8-hour shift, but individually, like you said, these are cases that you might see, and the way they deal with them, you think is pretty realistic.
I do, yeah. I think it does portray the range of what we see and do, but just I wouldn't do all of these things in one day or 1 hour. Certainly, this would be maybe over several shifts or maybe much longer, depending on how rare some of the things are. But they're pretty realistic of the challenges we face, both at an individual level, the types of things we see, or the system-wide challenges that they say. I mean, they talk about boarding in the show multiple times, and boarding is when patients have already been seen, they have a diagnosis or a plan, they're admitted to the hospital, and they get stuck, so to speak, in the emergency department because they just don't have a bed on the ward to go to. There's no space, so to speak, that flow issue. And another example that was used recently I saw was they were talking about using an AI scribe to help with documentation. And certainly that's a very topical and timely issue. It's something that we're trialing different scribes in our department, and many other departments are as well. So they're very realistic that way, I say.
That's really, really cool. I've heard people say it's the most realistic medical show, which isn't saying much because most of them are not realistic, sounds like it really at all, but I think it's really cool that they've done what they have with that show, and I think it's really interesting to hear, and literally an emergency physician perspective on it. Last couple questions. You talked about wait times you saw in the Pitt and how that's pretty realistic, unfortunately. I was going to ask if you can just speak kind of broadly about this, if you're comfortable, how big of an issue do you think is overcrowding in emergency departments just across the province of Ontario right now?
Yeah, so I think overcrowding is a huge issue right now across the province and across the country more generally. There is no doubt that the demand of the number of patients who are coming into emergency departments continues to rise year after year. We do see that locally. We see that at the regional, provincial, and national level. The other thing I would say is that concept of boarding, or where a patient has been seen, has a diagnosis, and is sort of waiting for their next step to be able to move, for example, go to surgery or maybe to a ward for further treatment, that's a huge issue. And that lack of flow or movement through each individual hospital and then through a region, a province, that's probably one of our biggest challenges, or our biggest challenge in the emergency department these days. I think, and so not only does it affect those patients who have already been seen and their experience, But remember, this causes a cascade or a backing up effect for everyone else who's coming into the department, because patients are now occupying rooms, but we're not doing a lot of emergent care with them, right? We should be going on to those next patients, and that's why patients are often being seen in sort of untraditional spaces or in, people are trying to be creative so that people don't have to wait as long. So I think it's very much an important, a significant issue across this entire country that I think we're all grappling with how to do this well.
Does it affect how your ability to provide timely care?
So not only sometimes is it that there isn't the right physical location to see a patient or the right monitoring to see a patient, there's only so many creative things you can sometimes do. And, we do our best in often challenging circumstances to keep people moving or to move people temporarily to chairs so that we can get other people into stretchers or different locations. But it definitely impacts, I think, their experience. It impacts wait times. It impacts the amount of time total that patients or their length of stay in the emergency department. But it also has an impact on our team and our providers. So, working in those types of conditions that are overcrowded time and time again, where that you're maybe not providing the best patient experience or people are being seen in areas where you never want to see someone in the hallway. You want to give them the privacy and the decency that everyone deserves. It weighs on people over time. When this happens infrequently, we can all, I think, kind of manage. But when that becomes a regular phenomenon at many of our hospitals, that's something that's really hard. And it's something that I think a lot of our providers, whether you're one of our nursing colleagues, one of our allied health team members, admin, or one of our frontline physicians, I think people do bring that home with them. And over time, I think it really does impact people's wellness. It impacts their joy at work and whether they want to come back because they see suffering. We work in an industry where we're trying to decrease people's suffering. We're trying to make people well or help them in their health journey. And I think these types of system-level challenges very much are the number one thing that I hear from my team that makes it harder. And I hear that even in some of our work that I do at the national level with CAPE, or the Canadian Association of Emergency Physicians. This is not unique to one hospital. It's not unique to one province. This is really a national challenge that we're all facing right now.
Wow. Thank you for speaking on that. That's what you said about it's making it hard for people to want to come back because you're just seeing further suffering, and your job is to actively try to make the opposite happen. I can imagine that'd be a really tough situation to be in. Is there anything, just lastly, that you'd want the public to understand about the state of emergency medicine in Ontario?
It's very hard because there isn't necessarily an easy solution. There isn't a silver bullet to this where we can all just kind of quickly turn this around. And I think because of that, I do think we all are in this together. There's going to be a point where probably everyone, either themselves or a loved one, will need care. And so a functioning and highly efficient emergency department that emphasizes quality, that is timely, and really gives the care they want, that's so important. It's something that's very important and sort of core to myself and I know our teams. And so I would say, for the public, that for everyone, it's important that we keep this top of mind, that we try to work together to find creative ways of continually doing this better. We know what some of the problems are, and it's challenging because there are limited budgets. There's also limited human resources. So these challenges all kind of act together, but I think the continued sort of pressure and engagement of the public is really important here too, so that we can make a system that we're all proud of.
Wow. Thank you for sharing that. That's really profound and very interesting. And you obviously offer a perspective that most people don't have. So thank you for speaking on that. I think I might just ask you one last lighter question. Something I like to ask doctors is, given their specialty, what's something they would never do? So being an ER physician, is there something you would never do? Is there something like a motorcycle you'd never get on or something like that, or anything that comes to
interestingly,
mind?
that was what I was going to say. So,
Okay.
I do have some family friends who ride motorcycles,
Yeah.
and I've seen enough accidents with motorcycles that you're really not protected,
Yeah.
whether if you have an accident yourself or you're struck by a car or otherwise. For me, it would be something that I just have no interest in riding a motorcycle.
Yeah.
No matter if you're wearing the helmet or otherwise,
Yes.
it's just one of those things I would not want to do.
Because you've seen the outcome.
I have. I've seen the outcome, and this to me is something that's preventable.
Right.
Whereas there's some other things, that we do that you kind of maybe can't prevent always being in a car, for example, or
Right.
otherwise. But we can make different choices,
Yeah.
and it's
Yeah.
just one choice that I wouldn't make.
There are other ways you can get around without a motorcycle.
Yeah.
Well, thank you so much again for coming in and answering all these questions. I found this very interesting. I really appreciate everything. Your perspective is so fascinating to me. So thank you so much. This is Dr. Justin Hall, and thank you for watching, everyone. And we'll see you next time. Bye.